Okay, well, what we're going to talk about this morning is an issue that we run across quite a bit when we're doing assessments and providing services for children and adults with autism and other developmental disabilities. And I want to talk a little bit about how we got to deciding to make this topic. We do work for a number of different places working on assessments and treatment for children with autism spectrum disorders through the TAP program and through Easter Seals, as well as through Forest City Behavior, my company. And one of the questions that comes up very, very often with families is that there's a lot of confusion with respect to what they've heard from different sources, different professionals, different bits of information about what the diagnoses and conditions are that their children have. And there seems to be a considerable amount of confusion about what that information means. So it's not uncommon, for example, to talk with parents and families and find that they've been told by a physician, for example, that their son or daughter has an autism spectrum disorder, but that the school doesn't agree with that assessment with respect to school eligibility and funding. We also see situations where things are the other way around, where kids qualify for school services, but they're finding that when they go into structured assessment like the type that we do, that they're not meeting full criteria for the conditions that they expected and so on. And we end up contending with a lot of hurt feelings and confusion on the part of those families. And so a lot of the purpose of this talk was designed in part to help me understand better why we end up explaining what the distinctions are and addressing that confusion as we work with families. So what you're going to see here is in part my effort to better understand what's going on with that situation, and as I was looking at it, to better understand if there are things that we can do to help decrease the confusion and make things more straightforward. So as we go through, we've got folks from a lot of different areas of expertise here. Some of you are in education, some of you are BCBAs, as well as in situations in between. Some of the things that I talk about you're going to have a lot of background information on, some of you probably more than I, and some things are going to be fresh and new, and it's going to vary from person to person. And I recognize that. So as we go, if you have questions and so on, please shout out and let me know. And I say shout out because I think right now you can see me pretty well. I can't see you at all, so just let me know. That's the purpose to the talk. That's why we put it together in the question that we were trying to answer. So that's what we're going to be talking about going forward. When I started looking at this, it seemed to me that the quandary that we were dealing with was probably something more related to this word. The situation that we run into often is families showing up and talking with us about what they've been told by different professionals with respect to the diagnosis that their son or daughter ought to have. And so they'll come in and they'll tell us that a teacher at school or a school psychologist or a physician, a pediatrician, etc., told them that their child has autism. And when they say that and we ask them about it, for them, this word is the thing that comes up. The child has been diagnosed. And I think part of the issue here is that word and what it means. Within the different treatment avenues that we do, we use this word quite a bit. It shows up all over the place, and it's in common usage in a very general way, right? So we see medical diagnoses being given for all sorts of things, and in fact, when physicians go through and they do treatment with you, you go into the emergency room. If you have a broken arm, if you have a boil to be lanced, if you have a rash, for each of these conditions, when they go through and they do treatment, they're going to do a diagnosis to go with that. And that's a medical diagnosis. But we see the word diagnosis used all over the place and in all sorts of different ways. We use psychiatric diagnoses. We have families and groups talking about educational diagnoses. And the word is in such general use that we even will see it used for more day-to-day sorts of things like a mechanical diagnosis. You take your car into the mechanic and you have that crack team of people look at it, and they're going to go through and examine and work through what's going on with your car to try and sort out what the problem is and get it to work right for you. And when they do that, a lot of times what they'll tell you they're doing is they're diagnosing what's going on with your car. And that really isn't what we mean when we're using that term professionally. But this is the way I think that families and people in general often think of the term. They think of it in a very general way that's going to be talking about just sorting out what the problem is. So to kind of start that process and sort out what seems to be going on and what the word means, I did kind of the modern day version of going to Funk and Wagnalls. I went to dictionary.com and dug up the definition for diagnosis. And this is what it said a couple of weeks ago. We're talking about medicine. We're talking about a process of determining by examination the nature and circumstances of a diseased condition, the decision reached from such an examination, and sometimes we're talking about determining the actual cause of it. Overall, the way that we think of this word is that it's something that is designed in order to give us a clear, fairly objective picture of what's going on with someone. And in our work here at the medical school, one of the things that we spend time with, the work that I do is with the psychiatric rotations that the medical students do in their third year. They come around and they go through and rotate through a bunch of different sites, some of it out at Singer, out at Rosecrance here in town, but then they also come out to Rockville Children's Home, which is a residential program for children with developmental disabilities, including autism. They come down to Jack Mabley Developmental Center in Dixon as well, and that's a state-operated program for children, or not for children rather, but for adults with developmental disabilities who have severe behavioral problems. And so we spend a lot of time when we talk about diagnostics with them, talking about what that means and what the purpose of it is. And in terms of diagnostics, something that's important to be aware of over time. You guys are familiar with the diagnostic manual that autism and other diagnoses come out of, correct? Okay, so it's the DSM, right now it's the DSM-4-TR that those come out of. And the DSM was developed as part of a process of improving consistency for diagnostics over time. Before the DSM was put together, most of the mental health diagnoses that people were assigned were given based on information described in literature. So a given diagnostician in a mental health center, in an institution, would have to have been familiar with papers on a variety of different topics to make a given diagnosis. And part of the challenge with that was that they discovered they had regional diagnostic clusters. So you would have, in the Northeast, for example, a lot of people in institutional settings in the big asylums diagnosed with schizophrenia. And if you went to the Southwest, you'd discover that people who had the exact same symptoms would, for example, all be described as having bipolar disorder. And so the original design of the diagnostic manual, which was a tiny little pamphlet, was just to improve consistency and identification, to let us know for sure that we're talking about the same thing from region to region, from person to person when we see a collection of symptoms. But in medicine, diagnosis has a different additional purpose. It is designed to describe when we're working in medicine, but it is also designed to help direct treatment. And more, the goal within mental health is to have it do that as well. So what I mean by that is that when you get a diagnosis of tonsillitis, for example, which is fresh in my mind because my little girl is at home right now with a raging case of it, the physician uses diagnostic criteria to diagnose and describe tonsillitis so he knows what he's talking about. But the purpose of the diagnosis doesn't end there. Once he's made that diagnosis, the reason that that is of value to him is not just to describe and categorize, but to tell him then, what do we do for this? There's a typical understood frontline treatment for that condition once you have that clear diagnosis. And within mental health, we're getting more and more of that as well, and that's an ultimate goal for the use of those diagnoses. We know, for example, that if a person has major depression, that diagnosis is going to describe and categorize what's going on with them, but in terms of the research literature, we also can use that to direct what's likely to be the most effective treatment for them. For major depression right now, the most effective treatments are going to be a combination of antidepressant medications and cognitive behavioral therapy, just for example. And if the diagnostic manual is to be useful for us, it's going to be useful over time in helping us better understand how that works and what we should do for treatment. So diagnostics have both of those purposes tied to them. With respect to that, let's talk a little bit then about kind of our topic of choice here today, which is autism spectrum disorders. If you're here today, you probably have had some experience, some of you probably quite a bit, working with people with autism spectrum disorders. So this will be a little bit of review. But I want to present this, and my goal here is to talk about it in terms of what it means from the perspective of the diagnostic manual and how that's useful for us over time and in looking at treatment. Within the DSM-IV, we know that autism is a pervasive developmental disorder. And those words are carefully chosen. It's the entire autism category is referred to in this way. And this is really what that means. Pervasive is that it's lifelong. It's going to affect multiple areas of life. So here we have a condition that doesn't just affect things at home, but you're going to see affecting things at school for children, at work for adults, in family venues, in public venues, and so on. And that's certainly a fair description for most of the folks that you work with who have autism. Particularly for kids who are severely affected, you can see if you're out at the mall and parents are walking with a kid who has significant symptoms of autism, you can see that. You can see it affecting what's going on with them. And honestly, for a lot of the families that I work with, if they have their child with a spectrum disorder at the mall, they're pretty brave. They've been working pretty hard on probably building those social skills and building that tolerance. Mm-hmm. Developmental refers to where it appears in the life cycle. And a developmental disorder in general is one that begins at or shortly after birth. In the very big picture, we think about this as happening before 18 years of age. But for autism and the other spectrum disorders, we're particularly concerned with that happening, at least evidence of it being present before 3 years of age. And then vitally important to this is that the symptoms that we're talking about present as a disorder. Day-to-day life, day-to-day functioning have to be affected, and if affected in a way that significantly impairs what's going on with the person. And this is something that can't be overlooked or downplayed. One of the things that shows up often, just as an example of this, is you will get from people periodically, it used to be on paper, now it's in email, but you'll get these lists of different famous people who had different mental health conditions. So the one that immediately comes to mind for me often is that Alexander the Great had epilepsy, Julius Caesar had epilepsy, and so on. And one of the most famous people that I see often listed as people who may have had an autism spectrum disorder, specifically Asperger's disorder, is Thomas Jefferson. Is this something you guys have seen? Yeah. And I find that interesting, and I understand that it's often of value for parents because they want to be able to see hope and see opportunities moving forward for their kids, and having that comparison says, okay, yes, my son or daughter is different, and we're going to have to work on this, but look, here is this immensely successful person who had this same condition. I think, unfortunately, it ignores this component. Particularly when you consider that here is a person who was immensely successful in politics in a developing nation, which is an intensely social activity. I have no doubt that the man was unusual. He obviously was brilliant and had some phenomenal skills that were focused in very intensive areas in life. Probably happened his entire life and covered multiple areas of his life. But I think it's a stretch to describe him as somebody who was disordered. I think, strictly speaking, he may have had a lot of the features of a spectrum condition, and that's debatable. But to describe him as somebody who would meet the criteria for a disorder, I think, is underselling the role that that plays in understanding what we're talking about here for different diagnostic conditions. A little bit more on this. When we think of autism in particular, and we think about the disorder component, where we see those disorders are in social skills, right? Particularly social relationships, understanding how to approach people, interact with people, and so on. We see difficulties and differences in communication. And the reason that I say differences in communication is because we certainly do have a wide array of folks with spectrum disorders who are nonverbal and who have very limited verbal skills. But even when we get into higher functioning folks who have conditions like Asperger's disorder, who's worked with kids or adults who have Asperger's disorder, right? Excellent. Are there differences in the way that they talk? Okay, what are those differences? Okay, the little professor, yeah, excellent description. Exactly. They're doing, in a general conversation, what I'm doing here today. Right? They're going to tell you about what they're interested in, what they want to focus on, and if you're lucky, at the end you may have an opportunity to comment on it. And it probably won't matter what your comment is, right? Because the information has been conveyed, and that's it. That's what they were there and engaging in the interaction to do. And so where we have language skills, it's important to realize that even where we have them, there are differences in how it's presented. To expand on your point a little bit with folks with Asperger's and similar types of disorders where we have intact language skills, is that it's about them. It's about them, and it's often intensively focused on very narrow areas of interest. Right? So you end up in a conversation with someone who can tell you everything about the type of trains used for public transit in Boston between 1953 and 1956. That's an intensive focus, and it's a difference in terms of the type of conversation that you're going to have with the average person. That third category, then, that we see difficulties with are the stereotypical and ritualistic behaviors. We see all three of these in autism disorder proper, which we'll talk about just in a little bit more detail here in just a few minutes. But in particular, well, actually, for the most part, unless we get into the category of PDD-NOS, I often see some of this with almost everybody who meets the spectrum criteria. It's rare that I work with kids who have just something out of two categories. For a couple of the diagnostic criteria, like Asperger's, there's supposed to be no delay in language. We do see that, but not a delay in language doesn't mean that the communication differences aren't there. And while we don't always see ritualistic or stereotypical behaviors, we don't necessarily see things like finger looking or rocking from folks. I see a lot of ritualistic behaviors. And when we do behavioral treatment, that's often at the top of the list for the folks who are brought in for crisis. Right? Is you're going to see somebody who is intent on doing something a specific way, and then we have difficulties when others around them are intent on it being not done that way. Another thing that goes through with this is that we now think of autism as a spectrum disorder. This is a term that's been showing up in the mental health literature for the past several years. To my mind, it's actually synonymous with or a replacement for the word syndrome. The spectrum disorder is essentially a situation where you have a collection of symptoms that vary from one person to another in intensity, in presentation, and sometimes in collection. But it's clear when you look at the group, you're talking about very similar things across the group. Within that spectrum right now, diagnostically, we have several different conditions. Most of these, if you've been working in the field, you're probably somewhat familiar with. We've all probably seen folks with autistic disorder. If you're working in schools, you've seen kids with Asperger's disorder. You've probably worked with kids who have PDD-NOS. Anybody worked with anybody who was diagnosed with childhood disintegrative disorder? No, and me either. I've never actually seen or diagnosed a case of that, and that seems to have been added in part to account for folks who where symptoms seem to show up later. And there are some other things that go with how it presents. One of the diagnoses that's on the current list is also Rett syndrome. And what's important to realize about this is that the current diagnostic list within the DSM-4 came out in 1994. The DSM-4-TR is more recent, but they didn't change any of the diagnostic criteria. And Rett syndrome was part of that list at that time. Since then, researchers have actually diagnosed the cause to Rett syndrome. It's a genetic condition, comes from a mutation, and I expect that this will be removed if and when the DSM-5 ever comes out, so that's why I cross it out. But what it means is we have a broad array of things that we see with autism spectrum disorder. And we see specific things with it. When we talk about impairments in social interaction, we have pretty specific criteria about what that means. When we do give them a DSM-4 diagnosis, we have to hit at least two of these. Right? We have to have poor nonverbal communication. So this is the stuff that happens when somebody is talking to you or interacting with you that they do with their bodies. A lot of times folks will think about this as eye contact, and that can be one of the things that we see. In particular, people will focus on whether somebody makes poor eye contact or no eye contact. But even within that area, we get quite a bit of variability. I've worked with kids and adults who make excellent eye contact, so much so that they never look away while you're talking with them, right? And so you're uncomfortable, you're trying to find anywhere else to look, and every time you look back up at them, there they are. Probably because somebody has told them they need to make eye contact when they talk. But it's also body positioning. It's understanding that you look towards somebody when you have a conversation with them. It's all sorts of things within there. Right? We often will see differences in the peer relationships that people have. You may have kids who are higher functioning with autism that can play well with adults, with their parents, but can't figure out how to navigate that relationship with anybody within their class, their school, and so on. Lack of spontaneous attempts to engage socially. What does that mean? Can we talk a little bit more about it? Mm-hmm. I think that's an excellent description, and I like what you said about maintaining the relationship as well. So if you can walk into a room, and if the child is sitting playing with organizing things on the floor, for example, if you could stand there for a half an hour and the child would never turn and look at you, right? This is a child who is not attempting to engage spontaneously. If you're having a conversation, you walk up and you say, "How are you doing?" and they can respond. But that won't happen without you engaging in that. Okay? That's a failure to engage socially. And in addition, the reason that I said I thought maintaining is a nice example, because we do have kids where we can teach that initial give and take. But if you haven't taught the next step in that communicative structure, if they then kind of stand and look at you because they have no idea what to say next, that's a part of what we see here. And this is a challenging thing, I am certain, within classrooms and schools, because now you have a kid who, when you pick up and it's time to go into a group activity, for example, it doesn't occur to them that that's something that they ought to be moving and participating in without direction from others. It's certainly something that parents struggle with when they're trying to build and grow the relationship with their kids. So excellent examples. And the lack of social or emotional reciprocity. What we mean here is, well, social and emotional, but give and take. It's taking the other person's perspective and understanding how the other person feels, giving that back. So when you say to somebody, you know, if you walk into and you're having a conversation with a child who is on the spectrum, and you say something like, you know, my grandmother died last night. Often what you'll see is that is regarded as just another piece of information. And from the perspective of our kids, it probably is. It's not, you know, certainly nothing personal is meant by it, but there's not an understanding. And you know, some of us are better at this and works at this with respect to life outside of the spectrum. You know, not knowing what to do at a funeral, not knowing what to do in other places. But when a friend says something like that, generally speaking, you have an emotional reaction that goes with it. And what we see with our kids is not necessarily not the presence of an emotional reaction, because we can't see that, but no outward demonstration of it. And the reason that I say that way is I have worked with kids who down the road will tell you how badly they felt about something, but they don't display it. It shows up differently than it would for somebody who is not on the spectrum. Mm-hmm. Mm-hmm. I would still put that in there. That's probably a kid who's meeting that criteria, and obviously we evaluate on a case-by-case basis. But reciprocity, I think that's a good question. Reciprocity implies more than just understanding. Reciprocity is demonstrating, giving back that feeling, giving a response that is what you would expect from most people when confronted with that emotional experience. And for autism proper, autistic disorder, we need two of these criteria to be met. So that social interaction component, when it comes to autistic disorder proper especially, as opposed to, for example, PDD-NOS or Asperger's, is probably the most important component of the disorder in terms of what we need to meet. We also see impairments in communication. For a lot of kids, particularly lower functioning kids or more severely affected kids on the spectrum, we see significant delays in language. We see kids with no spoken language at all, and with no attempt to compensate. And what we mean by that is that the child doesn't demonstrate any spontaneous, any direct attempts to get their information across otherwise. So, you know, not only are they not asking you for a snack item, but they're not taking you, they're not pointing at the snack item, they're not, you know, finding a picture of the food and showing you. There just isn't an attempt to compensate for that. Oftentimes, the kid who has the kid with autism who has trouble here is also going to struggle with learning something like sign language early on, because it's not just the spoken language; it's the compensatory social interaction component of language as well. Okay? And this one looks a little bit duplicative. When speech is present, the person has difficulty initiating or maintaining a conversation. Okay, we see a little bit of that in the previous diagnostic list, and this is really speaking to the same thing. Stereotyped or repetitive language or idiosyncratic language. What is meant by that? What have you guys seen? Have you worked with children, for example, who use the same, they have some spoken language skills, but they are repeating the same phrase from a commercial over and over and over? Not using it to communicate anything to you, but because they enjoy the way that sounds. This would be an example of that. So in fact, and we'll get to the stereotypies, the ritualistic stuff here in a minute, but this is a version of that within the language. We're repeating that same phrase over and over again. It's used in a repetitive way. Idiosyncratic language, you have folks that use a descriptive word to actually get something to happen, but this is the only child that describes it that way. Okay? So if you're working with kids who have names for things that are not the actual name for things, but they call, you know, every stuffed animal bear. And so there's a stuffed dog over there and they're saying bear, and everybody is trying to figure out what it is that they want so that they stop being upset, because it doesn't make sense that he could be referring to that, because that's not what it is, right? It's idiosyncratic language, where we have language used specific to the child, often in ways that other people are going to have difficulty understanding. Okay. The last item on here is lack of varied, spontaneous make-believe play or social imitative play. So here what we have is, for a child who's 5, 6, 7 years old, they're not playing with other kids. They're not playing with toys in a way that suggests that they've learned what those toys are supposed to do from watching other kids, from watching their parents, and so on. It's speaking to that ability to watch others and learn in a social context. So you have kids that, for example, you give them a fire truck, and the fire truck doesn't roll along the ground, but the wheel is turned up and spun and watched over and over and over again. Might be an example of this. And it's make-believe play or social play relative to developmental level. So relative to their chronological age, and sometimes that's taken to look at relative to where they're at developmentally overall if there are delays. The third category for autism proper is the restricted and repetitive stuff. Rituals, stereotypies. There's a variety of items here. First is that encompassing interest in something. Right, so we've got some topic that we're fascinated with, we want to talk about over and over and over and over again. And there's some variety in this. I've worked with a young man, for example, who's very, very bright, who's fascinated with the weather. That's all he wants to talk about over and over and over again, is he wants to talk about the weather. And what's important to realize, too, is that said, it's not the only interest he has, it's just a particularly focused one. These can change over time, too. So the child who is fascinated in the weather today may be fascinated in trains next month, may be fascinated with, I don't know, the political situation in Libya the month following. And what we see, what's important about that is not that it's necessarily the same thing all of the time, but that when it's the object of interest, it's the object of interest. This is something that the child is talking about all of the time. They're focused on it. It's something that they live and breathe for the time period that they're into it. Inflexible adherence to specific non-functional routines or rituals. And I think this one gets a little bit complicated. Non-functional rituals, now that can be anything from needing to spin 3 times before you go through the door, right? Needing to touch things on the way out the door. We see things like that. This is actually a pretty broad category and can include previously learned activities that no longer apply. So for example, if you have a child who has been taught to lay out the clothes in the order that you put them on in the morning to get ready for school, to make sure that he has everything there, and he meticulously does that in the pattern that his mom showed him the first time that she taught him, and because he does this, now that he knows exactly and can ensure that everything is on, or that maybe other accommodations have been made to help him get through that, still does it, and it takes him an hour and a half to get ready in the morning because of the pattern that goes with that. That's no longer functional, but it's still there. That makes sense. Something that we see a lot of variability in. That non-functional part is important. If you have somebody who is going through their day and has learned to organize things in their lockers in a specific way because they have trouble remembering to grab the right thing on the way to class, and it's real important to them because that prevents the anxiety of not having the right materials in class, it could be an intensive focus, something that they're unwilling to give up on, but from their perspective at that point, it's functional and it may be useful. And so that distinction is important. Stereotyped and repetitive motor mannerisms you're probably familiar with. And this one also includes persistent preoccupation with parts of objects. So there's those wheels on the truck again. You may find that you have a child who is not just interested in wheels on the truck, but on cars, on anything that spins. I work with a gentleman who anything round was a fascination. And that was everything from dartboards, which he would carry with him everywhere he went, to garage sale, the little garage sale stickers, which he would then arrange in patterns on different things. I think we cornered the market for a period of time on garage sale stickers as a reward program. And he's moved on from round. Now what he does is he requires a computer with Microsoft Paint installed, because he goes through and he makes diagonal patterns 1 pixel at a time, row after row after row of yellow, white, yellow, white, yellow, white. And it's very hard to get him to stop engaging in that. A couple of other things about what goes into this, the diagnostic criteria, right? Those delays in social interaction, language, or symbolic or imaginative play, one of those categories has to be present prior to 3 years of age. And it doesn't have to have been detected by a diagnostician prior to 3 years of age, but we have to have evidence that it's there. If you're working with a child who has an intact family, isn't adopted or what have you, a lot of times you can get this information in a way that is useful and helpful to make that determination. And if you're real strict about your diagnostics, if you can't make this determination, even if we're meeting all of the other criteria, we're not going to meet a diagnosis of autistic disorder when we're doing it. Now we're going to probably be in the category of PDD-NOS until and unless we can get that early developmental information. So how do we get there? When we're doing diagnoses, we use a number of different things. I'm going to talk about these briefly, some of them you'll be familiar with. Always with families, we're doing clinical interviews, gathering information about that early developmental history, about the behaviors that families are seeing, why it is they're in for treatment, what sorts of struggles they may be having related to the condition. Often we're talking also about family background, family history. We use screening instruments and rating scales, and we do have a direct assessment option. The rating scales, you guys are probably all familiar with different versions of these. All right? Childhood Autism Rating Scale, I've given up here a couple of the Gilliam scales. Has anybody ever given an ADIR? I see no hands, and that does not surprise me. There are a lot of variety of these. The ADIR is put together by the same group that put together the ADOS. The reason the lack of hands don't surprise me is it's approximately 970,000 items long. And I have never heard of a family or examiner giving it without both being very frustrated by the time that it's done. So it's not real popular to do. However, it is important to remember when you're doing these that, with the possible exception of the ADIR, they're all screening instruments. The briefer a psychological assessment of any kind, the less robust it is in terms of reliability and outcome. So these are often useful if you've got a child, for example, where you see different things going on and you're saying, okay, well, one of the things that I want to consider here is whether I should be thinking about autism and spectrum disorders in general. And so you may do something like the CARS or the Gilliam to help you sort that out. The information in the manual is very careful to tell you that once you're done with that, you have an answer profile that does not diagnose the child, but rather tells you how similar it is to other children on the spectrum who were part of their evaluation pool. And this is just a short list. If you go do a search, you'll find a wide variety of rating scales. The other option is direct assessment. What we do for that is we use an assessment protocol called the ADOS, the Autism Diagnostic Observation Schedule. This is a direct assessment because what we're doing with this instrument is we're actually putting the child into a series of scenarios and evaluating their play and interaction in those scenarios against what we would expect from a typically functioning child, a child who is neurotypical or not on the spectrum. It's helpful compared to doing observations and things like that because it is a way to ensure that you see the different social conditions the child may encounter. You know, we talk a lot about doing behavioral observations, but anybody who has spent some time doing them knows that they are so incredibly hit or miss when you go out and try and catch. If you have an opportunity in your schedule to do one or two of them, the odds that you will catch the child on their 2 best days of their life are so high, it's not even funny. When I talk with families and clients about this, the analogy often I use is that it's like taking your car to the mechanic. Right? It's been making that noise, you've been driving around all week, you hear that noise, you take it in, the mechanic fires up, no noise. And that's what observations are like often, making it really difficult to pick up on the things. And usually if I don't pick up on it, I've seen enough of that happen now that I try to assure folks that I believe them, even though it's not happening right here in front of me. I believe that this happens the rest of the time. What this does is it really weeds out that particular type of issue because you're actually going to press the child and challenge them with specific social interactions and see how they respond. Well, I think that let me move ahead here because I think that we're going to speak to that, and then I'll if I don't remember, cut me off and let me know if I've not answered your question. I think that it's very important when we look at these assessments, and we use them across a variety of professions, a variety of people, that we understand the limitations that go with them. Right? Assessments tools are useful, and we can use the ADOS as a backdrop for this, because they provide contrast against the general population. So what I mean by that is they give you a picture of what you're seeing with the individual as compared to the broad spectrum. Spectrum is maybe not the right word to use today, to the broad group of people in the population, the general population, so you can see how they differ from that population. All right? They also, for autism in particular, they provide comparison to other children on the spectrum. So when you're doing a CARS or a GARS, for example, part of the way that that has been evaluated and determined reliable and valid to the degree that it has is by taking that instrument and administering it both to children who do not have an autism spectrum diagnosis, but then to children who have been diagnosed already and that you're confident in that diagnosis. And so what it's doing there is it's telling you how the child that you're assessing compares to that second group. How much do they look like other kids that have already been diagnosed? And in those respects, those can be tools to provide a guideline for use when making diagnostic decisions. But that's, importantly, the way to think of it because an assessment doesn't make a diagnosis. And this is where, when I was talking in the beginning about where the word diagnosis comes in, this, I think, is where the challenge is. I think we use it very generally, and in mental health and behavioral treatment we have, and probably in other parts of the field as well, we do have issues where we're using general use terms in a technical way, and so when we're talking to one another, we're not always talking the same language, even though we're using the same words. I have been at meetings when I first started my career in behavioral treatment and behavioral consultations, so proud of how well I understood all of the terminology that I'd been taught. I know I have been in meetings where I'm talking about reinforcers and punishers and all of these different things, and everybody at the table heard what I said, but I know they didn't hear what I was saying because they use those words differently than the way that I was. And I think we have the same problem here. So one of the things that it's important to understand is that what this word should mean when we're talking about autism and similar conditions is that diagnosis should mean the DSM-IV criteria are met. And you saw, that's why, part of why I just went through all of the different criteria is if this standard hasn't been met with respect to a psychiatric diagnosis, I want to be specific, if you can't meet the diagnostic criteria, then it probably doesn't matter what your results were on the ADOS. Does that make sense? Am I speaking to that? So I mean, now, if you have unusual results on the ADOS, something's probably going on. and something that needs to be evaluated. It's not that that's where we end, but the results on the ADOS don't make the diagnosis. I don't have specific information about the court cases you're talking about, but it would not surprise me to find that that's part of where the distinction lies. I think we have a communication breakdown with our families and with each other because we're not all talking about the same thing here when we say it. And I don't think, nowhere in this, as we go forward, because I'm going to talk about where some of the differences fall, nowhere in this do I think anybody's doing any of this on purpose. It just is how the situation has laid out, and part of it is how we use this word. So I think we're going to help improve ourselves and our treatment and our communication with each other and with families if we understand that this is what we mean when we use this word. And again, just to reiterate what I said a moment ago, that isn't to say that when a child has otherwise had unusual scores on those instruments that something isn't going on that needs to be evaluated, that there aren't issues that need to be addressed. But if we can't meet the criteria here, then we need to be looking elsewhere. And I don't know how much information we have for instruments like the CARS and the ADOS and so on, that if they come up but don't meet full criteria, about what that might mean. Does that make sense? Let me see. Okay. So they come up on the CARS as having met criteria. They're not meeting either the school or the diagnostic criteria, and so they get shifted over to a developmental disability qualification. And there's good and bad in that. If they're getting services, you know, that may be the vital component there. So let's talk about where this falls with respect to Illinois school code and how it fits in and where I think the differences are coming from. All right? Now, this is pulled out of the Illinois school code and off of the IDEA website. So these are the specific criteria that are used for autistic disorder within an educational background or context. And I'm not going to read the whole thing to you. You guys have it in your notes, but I want to highlight a couple of items here. All right? So what we're talking about when we're talking about autism as far as the school code goes is that we're talking about a developmental disability, significantly affects verbal and nonverbal communication and social interaction, is evident before 3 years of age, generally, and it has to adversely affect a child's educational performance. What's important to realize here is that these criteria are similar to, but not the same, as what we're looking for when we look for a medical diagnosis or a psychiatric diagnosis. I kind of highlighted the differences here. Right? When we're talking about the social interaction component for autism proper, autistic disorder, there's a little bit of variability on the other items on the spectrum, we are talking about at least 2 of the following items with respect to communication. With respect to social interaction. And for school qualification, what we have is that it's a developmental disability that significantly affects social interaction. The diagnostic criteria out of the DSM are much more specific, much more detailed in terms of what they require, which makes sense for their purpose because, again, we're looking for consistency in measurement over time. Right? We want the evaluator in Tallahassee to give the same diagnosis as the evaluator in Biloxi when they're seeing the same conditions. That's a big chunk of its purpose. The school criteria is much more open-ended. Okay. Developmental disability significantly affecting social interaction. We would think that it would talk about these things here, but it doesn't actually specify. Right? Communication, we have a similar situation. Right? It's a developmental disability for school, significantly affecting verbal and nonverbal communication. Again, without all of those specifiers. And I think when I started to put this together, I think visually the distinction, just when you see the size of the list from one condition to the next, helps tell the tale. And for autistic disorder proper, we have to have those stereotyped and repetitive movements as a component, or the engagement in inflexible and not non-useful rules. But for school, we are talking about ritualistic and repetitive behaviors almost as an afterthought. If you look at how it appears in the overall picture in IDEA, this is listed as other characteristics often associated with. Right, so we talk a lot in IDEA about, in that big paragraph, about social and communicative skills, and yes, this stuff happens also. Which is interesting because, at least in terms of the structure of that, because for kids who need behavioral treatment, at least within school settings, a lot of times this is the thing that we're spending our time struggling with. This and the inability to communicate. But usually they're tied together, where if they could just let you know what it is that they wanted to do, what they needed to complete, you'd be struggling a whole lot less. And there's another distinction here that goes back to the DSM big picture. And that is the difference in terms of what we're talking about when we talk about disability. Right? When we dig into the DSM, what we're talking about in that diagnostic manual is a disability present that reflects impairment in one or more important areas of functioning. Whereas educationally, we are specifically looking at educational performance. So hypothetically, and this is what often parents are struggling with and what I see us having the conversations on, hypothetically, given the differences in criteria, you could very much have a child who is struggling at home, is struggling making friends, is struggling when he goes to do things at the pool, in all of these different areas, but he's making A's. So could meet full diagnostic criteria for autism or an autism spectrum disorder, but not meet that school qualification. Now my experience with children in that area is pretty limited, because if that's going on, they're probably not coming in for a lot of behavioral treatment as well, right? I don't have a lot of experience with kids who meet full diagnostic criteria who probably also don't need help. I'm not saying they're not out there, but that's not my experience. So we're talking about different criteria and, importantly, different purposes. Remember that I said that a medical diagnosis is really designed to improve diagnostic consistency for identifying people, but it's also designed to help direct treatment and tell us what to do. Whereas that school criteria is really specifically designed to determine if a child meets eligibility for services under a specific special education funding line. Yes? Yeah. Well, in my experience is, you know, we work with a lot of families who come from a broad geographic area. And I guess what I can say to that is we see a lot of variability in terms of what school districts expect and what they use. So, and to be clear on that, our purpose here today is to talk about things in terms of getting to a place where we decrease this confusion. I don't know specifically what the right answer to that is, particularly in our budgetary climate and economic climate. But I do know that you can be in one school district and have that very broad definition where you're looking at how they eat and how that affects whether they can focus in class and all of that, and another district where they are just looking at test scores. We do see that variability. And I know that's got to be a struggle for families, particularly when, you know, they're talking with each other and they're doing focus groups, and one from this district is getting a ton of services, and from the next who has a similar child feels like they're getting nothing like what they're seeing the other district get. And we certainly see families moving from district to district and so on in order to try and affect differences with that. So am I answering your question? Yeah. Well, and I think that part of it goes back then to look at how broad those criteria are from IDEA. Clearly autism is a category that we're looking at, but it's considerably more open in terms of what even the information is. As far as I know, and I'd have to go back and look, and Lori, who's sitting way in the back quietly, may know the answer to this, I'm not sure the word developmental disability is clearly defined in IDEA. Yes. Yeah, the idea, a state can, to my understanding, make their criteria more stringent than IDEA, they have to meet the core component of it. So from one state to the next, you may see variability. And the other thing that you were mentioning is communication even across the systems within a school district, so that are they looking even at what kind of food the kid is eating, right? Do the folks within that nutritional setting talk about it? Do they talk about the social pressures that are specific to things like the bus, which is a crowded situation, poorly monitored? And anybody who's ever, as a child, ridden the bus to school knows that when you're 5, 6, 7 years old, it's a no man's land. As someone who was a tiny child for my age, I can tell you, scary environment. And that's without dealing with one of these disorders. Having that social impairment would have made that far, far more challenging. Right? And so it is, part of that is communicating those different components. Those are excellent, excellent questions, excellent. So I think we see a difference here in terms of what they mean and what we're talking about. And if we're talking specifically about, and part of the reason that I think this is challenging is I think the proper term for what we're talking about here for school is school special education eligibility or qualification. But a lot of times what we see families using, and I don't know if it comes from the team members themselves or if it's just the way the families interpret it, we see families using the term educational diagnosis. And once that term gets used, intentionally or not, I think for them it becomes the very same thing as a medical diagnosis. They're not making that distinction, and it's easy to understand why that would be confusing. How is one type of diagnosis different from another? If you are somebody who is given a diagnosis, and we may not actually have said that, doesn't that mean the same thing as when you go to your family doctor? I think there's a big point of confusion there. Who's able to make a diagnosis, a medical diagnosis? It's a pretty short list, actually. In terms of diagnostics, there's one that I didn't put on here because I found out about it afterwards, but I mean, physicians in general, and then the things under it are examples. And as we went through the list, this list was actually very difficult to turn out in terms of getting a comprehensive list of who does medical and psychiatric diagnostics. The way that you can think about it is essentially licensed practitioners. That seems to be the central core here with respect to what's going on. Right? So psychiatrists, pediatricians, neurologists, but your family doctor technically has the medical license that will allow that as well, and they may have, as a general practitioner, some expertise in that. It's up to the professional at that point to be ethical and honest about where their area of expertise is. So you may have an LCSW, a counselor who works a great deal with children on the spectrum, and they may be in a position to give an appropriate diagnostic commentary, whereas you may have a psychiatrist who only ever sees adults primarily with depression and anxiety disorders. And they should be probably referring out even though they're technically qualified to do that. The one that I didn't have on here is a counseling pastor, which I did not realize. It's also a licensed position. I've never met one, or at least not that I knew, that could also be on here. But it's a pretty short list. And part of the reason we make this list, we're going to be giving this presentation for parents as well, and I want to be clear as we talk about this about who is actually giving a diagnosis, because I want to help, I'm hoping this will help clear that up for them. And I think it's confusing for families as well, because we have a lot of professional positions that work in a clinical, in the clinical field, which are certified rather than licensed. And I don't think that our families and even other professionals from other fields necessarily always understand the distinction. But that distinction is an important one. Certification isn't the thing that gets you on the list. It may make you a very, very well qualified person. You know, a school psychologist, for example, often has extensive training in particularly IQ and achievement testing and different behavioral inventories. Lots and lots of training, which this doesn't really speak to. Unfortunately, a clinical psychologist who does nothing but that behavioral treatment is actually in more of a position to make the diagnostic call sometimes than folks who are not who have more training. To illustrate kind of how this distinction and confusion has affected how we see things and what's going on within the field, let me talk just a little bit about our rising rate of autism spectrum disorders. And this is something probably everybody is familiar with. And we have been struggling for the past several years to describe and understand why that rate of autism diagnostics is going up, right? Everything from talking about differences in what it looks like, talking about increased awareness, and talking about, do we have something in the food, something in the water, something in how we treat people medically that's contributing to this. And those questions certainly haven't been entirely answered. But it is important to understand that this difference in understanding with respect to diagnostics seems to be contributing this. There are differences in how the rate of autism has been assessed over time. Those older, smaller numbers were predominantly based on special education qualification. And as we've just spent quite a bit of time talking about, that special education qualification does not equal diagnosis. But when we talked about those lower numbers 5 years, 10 years ago, that's what they were measuring, is which kids are getting services on an autism qualification. And all of those measures that you've been hearing about in literature are specifically on children. Now, to some degree, this shows up in larger and larger numbers just because the diagnostic criteria have changed over time. The original DSM and the DSM-2 mention autism only as a symptom of childhood schizophrenia. It's not a diagnosable condition. So when you get back into that era, you're not going to have it show up at all because it doesn't exist as a diagnosis. And in the DSM-3, the DSM-3R, and the DSM-4 each have different diagnostic criteria, making the picture somewhat different and confusing things for us a little bit. And certainly the DSM-4, with all of those different categories within the spectrum, is broader than older measures. So that's part of what's going on. But this measurement approach, what we're counting, is a vital component of it as well. A study was done, and this got a lot of press in the US, that found, by looking at things a slightly different way, and I'm going to talk about what that is because that's the part that's important, the rate of autism is now believed to be right at about 1 in 100. You probably all saw this when it came out. There's all sorts of media surrounding it. What's important to realize with respect to this study that was published in the journal Pediatrics is that it's measuring things differently than the previous measurement approaches. They did not look at special education qualification. And to take a step back, part of the reason that that was an easy count was because school districts, state by state, all have to report that information. So when you're going in and you're trying to make a count of it, you don't have to take special effort to do a count, you just have to crunch the numbers, right? It is so much easier to do research on existing data than to go out and do measurements yourself. And so that's a tempting area to work. What they did here, instead of taking that existing data, was they surveyed, and this is astonishing, this is an NIH-funded study, so why they were able to accomplish it. They surveyed 78,000 parents. I mean, it's a huge sample. This is not something you see most of the time. And they asked if a doctor or healthcare provider had ever identified any of a child in their family to have an autism spectrum disorder. Single phone call to a single household. I think. That's my recollection. It's been a little while since I've read it, so that's my recollection. So it shouldn't have been multiple parents within a same household. They also asked if the child was currently diagnosed with an autism spectrum disorder. And they counted as one of those 1 in 100 if both criteria were met. So your child couldn't have been diagnosed when he was 5, but isn't currently diagnosed and still be on the list. Has to have happened before and has to have been current. This is where that 1 in 100 number comes from. So in terms of that rising rate, it's important to realize in part that that difference in criteria makes a difference here. When we're talking about the specific diagnostic criteria being used, we get different numbers. It doesn't mean that necessarily that other things aren't going on to account for some of that rise, but certainly there's a difference in measurement here. We're not counting the same things between the two things. And also of interest to me, I noted that the previous measures, because they're on special education, are all on children. And this study is on children, 3 to 17 years of age. And something that has nagged at me for some time with respect to that is anybody who has worked with adults in residential settings has absolutely had the experience, if they've done that for any period of time, of working with folks who clearly have autism and who have never been diagnosed. And so when they first started to talk about the rise in autism, one of the questions that came up was, well, has anybody looked at these folks? Well, shortly after, and this got virtually no attention in the US press, shortly after that pediatric study, the NHS, which is Great Britain's version of the NIH, did a very similar study. Now, it's a smaller sample, but it's still huge. They surveyed 7,000 adults in Great Britain using questions very similar to the phone study in the pediatrics example. So they asked those questions. Have you ever been diagnosed before? Are you currently diagnosed? And then to validate their results, they did the ADOS on a subset of the respondents, which is very cool. This has to have taken forever. Anybody who's done the ADOS knows that you got to set it up, you got to spend time, you got to pick the right format for the right person depending on where they're at, and they went through and did a validation check. And among the adults, they got a rate of 1 in 100. So these folks wouldn't be showing up on that child measure, and yet when we look at grown-ups, we get the same thing. We were using those special education qualifications, we were measuring something different. I think that there are things that we can do as professionals to speak more to what's going on with all of this. Well, let me, before I go on with this, any questions about those studies? I just jumped right ahead. Right. There's a couple of answers to that. There's the conservative answer, which is that we certainly don't know the whole picture, right? And I think that's an appropriate answer. We don't know as yet what leads up to autism. We don't know causes. When we are giving a diagnosis of autism spectrum disorder, as is true for everything in the DSM, we are giving a descriptive diagnosis. What I mean by that is we've got a collection of behaviors together described. That's how we meet a diagnosis. It is different than some of the things that we do in medicine. Now, there are things in medicine that are also descriptive diagnoses, but if you go through and you culture the bacteria in an infection, you have very specific information about what's going on. But usually what happens in mental health is that once you know what's going on, like the Rett syndrome, for example, it gets pulled out of mental health and put someplace else. We don't get to play with it anymore. So we don't know what's going on and what leads up to it. And I don't think this is a complete answer to that question. But I do think what this does is it tells us that we were measuring something different 10 years ago, 15 years ago, when we got the lower number of prevalence. And that when we look at the broad population and make sure that we're all talking about the same thing, that diagnostic criteria, we get numbers that are much higher, and then when we go look at the adults, we get those same numbers. The adults being a part of that presentation is important because it means they were probably missed back when we were doing that counting before. Something else I was going to say about that. It's also important to realize, with respect to that difference, this was what it was, with respect to that difference in criteria between diagnosis and school, that because the IDEA diagnosis, and you guys have already spoken to this, I just want to bring it around to that point, because that idea, that criteria in IDEA is considerably more subjective, you have that variability from one school district to the next. So within what you've been what was reported before, you guys are talking about how you see those differences where one school district is very strict and looks only at test scores, another school district is looking at the broader life experience, and probably still others are somewhere in between. Well, all of that is going to affect what they report that goes into those prevalence numbers that were used before. Does that make sense? I think that it's important because what we have then when we talk about the diagnostic stuff is when we're using the DSM criteria, we are talking about something that should be a more robust measure from one person to the next. It was designed to do that. It is not perfect by any stretch of the imagination. And I don't know what the rate of error is for it, but it's clearly we get something more consistent because we're talking about two different populations across two nations, and we get very similar numbers. Okay? So it's what she's saying, I think that's an excellent point, that in the 1940s they had what they thought was a rising rate of cerebral palsy in the population. But in fact, if I understand the point that you're making, what we in fact had was children born with disabilities that survive into probably at least early childhood and possibly into adulthood. Right. So it wasn't reflecting the number of children born with these types of disabilities, but rather it's a reflection of survivor rate. I think that's an excellent point. You know, I mean, we see that now where we have specialized programs, in fact, for children with severe physical disabilities as well as intellectual disabilities, and that's probably something that wouldn't have been needed 50 years ago. Not because what causes those conditions is more common, but because we have medical care that allows them to survive and get past that birthing process. I have a niece, for example, who was 2 pounds 8 ounces when she was born. And she's a high school student and a musician now. You know, I mean, that's not something that would have been the case for her 50 years ago. I think that's an excellent point. I think that we can change some of this on our end by being careful about how we talk about what we're doing when we do assessments. We're all, regardless of where we're at, in a position to provide information to parents and families about what it is that we see, what we think is going on. And I think that we can help decrease the confusion by doing some of the things that I have listed here. The first is that we have to be explicit about the limits of the assessments that we do. When we're talking about something like a CARS or a GARS, for example, and we go into any kind of meeting, whether it's a team meeting, an IDT, an IEP meeting, whether it's a family consult, following diagnostic activities, it's important that we be explicit when we've done that instrument about what the results mean, particularly when we're getting results that suggest that autism is something that ought to be considered. Right? And I know that for myself, I find at times when I'm very familiar with an instrument that I tend to under-explain. Because I've seen it dozens and dozens of times. You know, I know what that score means, this is what it means, and so on. And if a parent doesn't ask for more information, I run the real risk when that happens of them walking out with a very different impression than what I intended from it. Okay? And I sincerely doubt that there are any practitioners, certainly not people that I've worked with, who administer something like a CARS and have told a parent that the CARS says this, so your son has autism. I really don't think that's happening. What I do think happens is when you talk about that, this score, they scored real high on the CARS, this assessment for autistic disorder. I do think when we explain it that way, we probably have families who walk out and think that what that means is, my child now has a diagnosis of autism. And that's often the way it's presented to me. It's not that description of the testing, but a parent comes in and they say, so-and-so from this doctor's office says Jimmy has autism. And a lot of times we have to dig to find, okay, well, what exactly did they tell you? Did they give you anything that reads that diagnosis on it? Can you show me that report? Did they give you more? Because they don't think about it that way. Once they've been given the information, they figure that's what it means. So I think that even just in terms of what we played back and forth with a little bit with respect to something like the CARS is important to do. When you have that high score on the CARS, it explicitly says that this score is similar to that of other children who have been diagnosed with autistic disorder. And probably, I know for myself, one of the things that I need to do is make sure when I'm talking about that I say, now that's not the same as being diagnosed. It just means that that's an area we should look at. Now, no parent is going to want to sit, most parents won't want to sit and listen to an explicit description of what the statistical properties of a given instrument are and all of that. And if they do, I think I'd be worried. But being clear that this is just a screening, that it just tells us that more needs to be done or more needs to be looked at, is important. When you're doing these things as a part of an overall evaluation, it's important that the outcome of that evaluation, what it will and will not mean for the child, is explicit. I know from our end, one of the things that we'll talk about is when families come in and they want an autism evaluation, if they're struggling with things for school, or if they're looking for Social Security funding, or if they're looking for disability funding through the Department of Human Services. The question that they'll tell us, I want you to give him this diagnosis so he can have this funding. Well, I can do an assessment. I can write the assessment to speak to the criteria of funding or qualification. But it's important that they understand that just because I write that down doesn't mean that's what happens. And I do have families who again, are confused about that, and that it takes time to make sure that that's clear and that it's understood that what the assessment will do. If we're doing an evaluation for school purposes and for special education qualification, I would think it would be important to be clear with them that when the child meets criteria for, the eligibility criteria for special education under an autism qualification, that's the limit of what it means. And if they're not understanding that, and that's why it's important to check for understanding, talking about that a little bit so that they're clear that the one thing doesn't necessarily mean the other. Now, obviously they're very closely related. Probably the majority of children who have a special education qualification for autistic disorder, for autism, also meet the diagnostic criteria. But it's not a one-to-one correlation, and it's important for families to understand that. And by the same token, when you're having that conversation with them, I think that it's important that we be prepared to refer. Because I expect that when you're having that conversation, you're going to find that they're going to say to you, well, then if this doesn't mean a diagnosis, what do I have to do to get that? Right? And I know these referral lists, for a lot of us in this region, are short. Where do we go? But being able to answer that question, I think just from a general satisfaction point from the parents, if you have someone or somewhere to send them, you're going to find that they're more satisfied. And they understand then that if they're also looking for Social Security funding or DHS funding or a medical diagnosis, this is the person you can talk to about that. That there's a place to go and to answer that question. Because I think that when we leave them on both ends with just, here's the paper and this is what it means, I think there are a lot of questions at that point where they feel they're just kind of hanging. What else do we do? Where else do we go? Thoughts about that? Let me just repeat that a little bit so that to make sure that everybody heard it, and then we'll talk about that a little bit. So what you're talking about is families who will go and get, say, a diagnosis, a diagnostic evaluation by a pediatrician or a neurologist, who then sends with them a prescription for an IEP, right? And does that ever work? Sure. Well, and one of the things, and we'll be giving a slightly different, because we want to speak to the parents' needs specifically. We're doing the same talk for parents, and there's some variation in this section. And one of the things that I think it's important, and this falls under that referral component, for parents to understand and for us to understand when we're referring is if you're talking with a parent before you get to the point of an IEP where they're looking for evaluations, looking for answers, and looking to have their child's needs met, if they're going to an evaluator, they need to be explicit with that evaluator as to the purpose for the assessment. And wherever possible, they want they want to try and find an evaluator who can speak to educational needs. I have to believe, for you guys that are in the school setting, because I know that it is, for me, from the other end of it, having a single-page consult note from the neurologist that says meets criteria for autistic disorder tells you nothing about what this is going to do or impact with respect to education. So it doesn't really even tell you if you need to do an education evaluation, right? Because there still have to be educational issues to be addressed to trigger that evaluation. Am I right in my understanding of that? Sure. Right. So the parent can, through the channel. So a parent can prompt at least some part of it to happen. But how far it gets is still going to be determined by what the school sets as criteria and what goes into the evaluation process. So it's important that we understand when we're sending parents places, and that they understand when they get there what they're asking for, and that evaluations that they're getting speak to these things. It's not terribly helpful just to have the disorder diagnosed, but also, okay, and in what way does this affect the child? Where is the impact? What's going on here? Excellent. Excellent. Something else I want to speak to this, and I actually meant to mention a little earlier, but I don't want to lose track of it. That difference in eligibility criteria. One of the things that it means is that for professionals who are working with kids in a situation where they're trying to figure out what the appropriate approach is for kids, is that probably we can't rely on the eligibility criteria alone to direct treatment because of that variability. That makes sense. So when we meet a full diagnostic criteria for autistic disorder, as it's outlined in the DSM-4, what that is designed to do, in part, is to direct treatment. Now, we don't have a way we don't have specific guidelines for treatment for everything that's in the DSM. So it's an imperfect system. But one of the nice things about all of the attention that's been paid to autism over the past 10 years is that we do understand, once we have a diagnosis, what it is that's effective for that. I'm going to put a couple folks on the spot here. I got a couple of BCBAs sitting over here. So what is it? What works for autism once we know it's there? Okay, communication training, right? What else? Okay, social skills development, and is it touchy-feely stuff where we're talking about how people feel about talking to each other? Right, so it's very detailed, task-analyzed, step-by-step instructions on how to approach social interactions. So absolutely. So it's the maladaptive behaviors come in. A lot of times, to take a quick step back, we see those maladaptive behaviors coming in secondary to the communication issues and to the ritualistic stuff, right? Where a kid really wants to spend all day stacking cans in the corner, and we really need them to do more than that academically. And so we have that conflict there. The reason that I think that that's important is because for you guys coming in from the outside and for the folks within the schools as well, when you're looking at that, I would be conservative about either accepting or rejecting whether this treatment path is appropriate based just on school qualification, if that makes sense. Right? So if you've got a child who is, the school has called and you're dealing with issues and they haven't been evaluated medically but they have a school qualification, I wouldn't necessarily assume based on that school qualification that the stuff that we typically do for autism is the right course for that child. Right? I would not shortcut in that way, if that makes sense. Well, that's a separate question. That's an excellent point, and I think that's a slightly separate question from what I'm trying to get at. Always, before you start doing any kind of behavioral treatment, psychiatric treatment, what have you, when we do evaluations, we make sure nothing's wrong. Because all that other stuff isn't going to matter at all if a child's got appendicitis, if they've got chronic earaches, if they've got, those things need to be addressed first. Where I'm going with is once we have a medical diagnosis, that should tell us, for example, given the list that Joe gave, the sorts of things that we need to do. I wouldn't go in and reject that list if a child doesn't meet the special ed qualification, nor would I jump right to that list if they do. I certainly wouldn't ignore it, but I wouldn't use it as a sole treatment direction criteria. Does that make sense? I know it's kind of a subtle point, but that there means that you should think about it, but do some additional assessment and make sure you're on the right path. Excellent. All right. So in a nutshell, we have different criteria between the two qualification areas, and they're for different purposes. And I think that in the big picture, all of this results in challenges in communicating across fields, across professionals, and certainly between different professionals and parents. I think that the bulk of this we can best directly address by improving our communication. Being much more specific about what we say and how we say it and what the limits of what we're doing are. Thanks for your attention, folks.